Greetings and welcome to the PEDReady and Florida EMS for Children Safe Pediatric Transport Educational Content. My name is Marshall Frank. I'm an emergency physician at Sarasota Memorial Hospital and the medical director of the Sarasota County Fire Department. This content was put out by the Florida EMS for Children subcommittee working group and was reviewed and approved by the Florida EMS for Children Advisory Committee with support from a HRSA EMS for Children state partnership grant. I'm going to put up a disclaimer here that you can take a look at. I'm not going to bore you with reading it, and we'll leave that up for a couple of seconds and then we'll move on. So our working group had three objectives when we formed. One was to develop a position statement that can be put out throughout the state by Florida EMS for Children, indicating how important EMSC thinks safe pediatric transport is. So that was the first objective. The second objective was to develop a sample policy that EMS agencies and fire agencies could use internally to develop policies of their own regarding safe pediatric transport. And the third was to develop this educational content to be given either in person or virtually to encourage safe pediatric transport. And the objectives of this particular educational content is to, one, identify risks involved with transporting pediatric patients. Two is to identify resources available for restraint of the pediatric patient. Three is to learn about the National Highway and Transportation Safety Administration's efforts to improve child safety and their specific guidelines for ambulances. And finally, to identify developmental age distractions for separation and securement of the pediatric patient. So we're going to start with our first objective as the group and discuss the Florida EMS for Children Safe Pediatric Transport position statement.
Hi, this is David Summers. I'm a nurse and a paramedic and a certified flight registered nurse. I'm with the Healthcare District's Trauma Agency in Palm Beach County, and I'm the Trauma Nurse Outreach Coordinator. The Florida EMS for Children Safe Transport Position Statement is comprised of state pediatric, emergency, trauma, and EMS professionals. Basically, what we have done is we have brought in all of our partners throughout the state to try to come up with some best guidelines, some best position statements. All infants and pediatric patients should be transported using a commercially manufactured, appropriately sized pediatric restraint device. EMS and fire personnel education regarding safe transport should be conducted through a variety of educational methods in order to understand restraint guidelines and select devices. The Florida EMS for Children Safe Transport of Pediatric Patients online training resource, hands-on training, and community education. Agencies are encouraged to implement a safe pediatric transport standard operating procedure or protocol. Florida EMS for Children Safe Transport position statement has been endorsed by many of our Florida EMS Advisory Council constituency groups, to include the Florida Association for EMS Medical Directors, the Florida Association for EMS Educators, Florida Association for Critical Care Transport Specialists, our Florida Emergency Nurses Association, the Florida Fire Chiefs Association, the Neonatal Pediatric Transport Network, the Peer Committee, and the Florida Association for Rural EMS, and a few others that have reviewed this program and have given their endorsement.
Great, thanks, Dave. Just a quick background about EMS for Children. EMS for Children is a national organization and also a statewide organization. The national EMSC mission is to optimize outcomes for children across the emergency care continuum by leveraging quality improvement science and multidisciplinary and multi-system collaboration. Now, in terms of the Florida EMSC and PEDReady organizations, their goal is to enhance pediatric emergency care readiness and preparation in emergency departments throughout Florida and EMS agencies in Florida. This year, a key state objective was to work with Florida EMS agencies to enhance the safe transport of children from newborns to teens by providing free access to educational tools, sample protocols, and resources. And why this is so important is that there are a lot of pediatric transports throughout the United States and throughout Florida every year. We receive 30 million emergency calls per year. 7 to 10% of those are pediatric transports. And of those 30 million calls we receive per year, 6.2 million transports occur per year. So about 10% of 6.2 million transports a year are pediatric calls and pediatric transports. And you can see crash data that was put out in 2019. Data from 2010 to 2019 shows that there were 5,954 motor vehicle crashes involving ambulances. 25% of those resulted in injury, and unfortunately, 25 people in that time span were killed. Of those fatalities, 56% were occupants in other vehicles. 29% were occupants in the ambulance, where there were passengers in the ambulance, and 10% were non-occupants, such as pedestrians and so forth. But if we imagine, as the previous slide showed, that 10% of cases involve pediatric transports, we can see that that this is sort of a low-hanging fruit, and that we know that there's a lot of pediatric patients involved in motor vehicle crashes and ambulances. And we can see also that NAEMSO gives us some information regarding what they feel is important in terms of safe pediatric transport by this statement. And it says that safe ambulance transport should be considered as a standard of care for the EMS system, equivalent to maintaining an open airway, adequate ventilation, and the maintenance of cardiovascular circulation. So you can see that big organizations such as NAEMSO, really support and advocate for the safe transport of pediatric patients. The number one thing to avoid is allowing a parent or another caregiver to hold the baby in his or her arms. We know that in the field after a baby's born, or if there's a child that's injured, the mother, the father, the caregiver, naturally wants to hold the child or the neonate in his or her arms, and we know that this is not safe. During an unanticipated collision, our natural instinct is to extend our extremities, not hug ourselves. So if a parent's holding their baby and the ambulance is hit by another vehicle, then the baby's no longer secured in the arms, and become airborne and hit the side of the ambulance and really become injured. And that's a huge reason why this is so important. So in May of 2000, NHTSA put out a couple of things about pediatric safe transport, specifically do's and don'ts. And what we want to bring to your attention are the ones that are labeled with the yellow arrow. And you could read the other ones yourselves, but the ones that we felt were most important are the ones that we indicated with the yellow arrow. And those are to ensure available restraint systems are used by EMTs and other occupants, including the patient, and to transport children who are not patients properly restrained in an alternate vehicle whenever possible. So if there's a motor vehicle crash and the mother is injured, but the child's not, try to have that child transported in another vehicle, maybe by another family member or police officer or somebody else, if at all possible. And moving down to the don'ts that we felt were important were to not allow patients or caregivers or EMTs or other passengers to be transported unrestrained, which is a pretty simple concept, and also to not have the child or infant held in the parent or caregiver's arms during transport. And we already discussed why that's so important. So we're going to move on and discuss a case briefly.
Hey everybody, Nikki Shimko here. I am the manager of Golisano Children's Hospital of Southwest Florida and Fort Myers, the transport team here, and a member of the EMS for Children's Committee. we talked about it just a minute ago about how, you know, if you're not transporting a patient and they're in the arms of a child, you know, or the parent, that there other things could happen. So we did have a patient case that was really impactful when discussing all of this. A 7-year-old female with asthma attends a poolside party, and she begins having some mild coughing and wheezing. The parents go to their car to retrieve her inhaler and return to the party, and they cannot locate the child. The child at this point is then found underwater, and she's frantically pulled out of the pool, begins coughing and breathing. 911 is called, and the child is en route to the closest ED. So she's sitting on the mother's lap because they felt like she could breathe better on the mom's lap. An SUV going 60 miles an hour crashes into the side of the ambulance. The patient and the mother themselves both fly across the ambulance and sustain head injury. So now you have an asthma, somebody who has had a near drowning in the pool, and now has a head injury. They're both trauma alerted to a level 1 trauma, and another ambulance is called for transport. So it speaks to the impact of having the child restrained to hopefully avoid any further injuries. Products to you all, agency, we and have them commercially approved devices that are there for you. We do not have any bias on any of these. We are simply providing you, we're not endorsing any of them. We're just providing you the information for you, for your agency to choose the best one for all of you to use. So first up is the emergency child restraint. This is a set that it comes in 3 different sizes depending on the size of the child. And you can see some of the pluses and perks of this set. It is around $800 to $1,000 a set. And on the next screen, we're going to show a video of how to use it really quick.
The emergency child restraint is an ideal solution for securing and safely transporting pediatric patients on the ambulance cot. It is packaged in 3 ergonomically sized weight classes from 4 to 110 pounds, and each size is integrated with the color-coded pediatric Brasel system, along with the acceptable patient weight ranges for each size. The emergency child restraint unfolds easily, and fitting it to your patient can be accomplished in 6 simple and quick steps. Attach 2 cot straps on each side of the cot frame runner rail and pull the buckle through the metal ring. Select a correct sized harness. The Braslo color codes, along with the harness size and patient weight range, can be found on the harness and on the harness shoulder straps. The emergency child restraint system comes with a separate head support, which is ideally suited for smaller patients to minimize movement and vibration. If using the head support, place it on the mattress approximately where the patient's head will be located, and place the harness on top of the head support. The bottom of the harness shoulder strap should align approximately with the bottom of the head support. Now extend all the straps. Using the 4 belt buckles that were previously attached to the cot frame in step 1, click each one into place to the corresponding harness straps. Position the child onto the harness and bring the shoulder straps over the torso. Now bring the crotch buckle between the legs to meet the shoulder straps. Attach the shoulder straps into the crotch buckle and tug on the shoulder straps to tighten.
Love when videos.
Then click in the chest strap between each shoulder strap. Now that your patient is secured in the harness, pull the tabs on each cot strap to further secure the harness on the cot mattress. Your patient is now secure and ready for transport. Always follow your local protocols and procedures.
So that is a summary of the emergency child restraint. Let's go. As mentioned in the video, they do provide an infant head support that can be purchased separately. The ACR4. So this is a system that's been out for about 5-6 years now. They actually are phasing this out, so I put it on here for reference only. It kind of is being replaced with the emergency child restraint. So if agencies have them, you will move then to the ECR as these are phased out and made So now we're going to talk about Furno's apparatus that they have that can also be used. So there's the PEDready, the NeoMate, and the Kangoo Fix. The PEDready, which is well known across a lot of agencies, ranges from 10 pounds to 100, which is 4.5 kilos, to up to about 44 kilos. And you can read there some of the pros of this. They're about $350 to $400 each. And we're going to watch a quick video on this as well.
This video describes how to attach the Furno PEDready Plus to the NX Integrated Patient Transport and Loading System. It is recommended that training on the proper use of both products be provided before using them in an actual situation. Carefully review the user's manuals for both the PEDready Plus and NX for complete instructions on the use and care of each product. Prior to applying the PEDready Plus to the NX, remove all restraints from the NX. Raise the backrest between 15 and 45 degrees. Unroll the PEDready Plus and spread it flat on the cot mattress and extend the straps. Center the PEDready Plus left to right and position it so that the base of the PEDready Plus, where the patient will be seated, is at the joint of the NX. The black strap will be in the area where you expect the patient's shoulders to rest. Run the ends of the gray and black floating strap system around the NX backrest until they meet on the side, and then fasten the buckle. Leave some slack for final adjustments. Fasten a mainframe strap by threading the tang male end upward, with the buckle housing facing the center of the NX through the slot of the patient's surface near the head end of the NX. Wrap the strap around the slot and fasten the buckle. Leave a little slack in the strap for final adjustment. Repeat this step with the other mainframe strap. You may need to adjust the PEDready Plus's position on the NX to accommodate the patient properly. After doing so, tighten the backrest strap and both mainframe straps.
So that video showed you how to use the PEDready on the stretcher. I know most agencies leave their straps on there and just add the PEDready on when a pediatric patient is on the stretcher. Let's get this to move forward. So now the NeoMate. The NeoMate is made for 5 pounds to 14 pounds, so 2.3 kilos to 6 kilos. And again, there's the pros of this product. It also is about $350 to $400 each. And then we're going to watch another quick video. I'm going to skip through this.
The NX Integrated Patient Transport and Loading System. It is recommended that training on the proper use of both products be provided before using them in an actual situation. Carefully review the user's manuals for both the NeoMate and NX for complete instructions on the use and care of each product. Prior to applying the NeoMate to the NX, remove all restraints from the NX. Raise the backrest between 15 and 45 degrees. Unroll the NeoMate and spread it flat on the cot mattress and extend the straps. Center the NeoMate left to right and position it with the gray backrest strap at the point where you expect the patient's shoulders to rest. Run the ends of the backrest strap around the cot backrest until they meet in the back, and then fasten the buckle. Leave some slack in the strap for final adjustment. Fasten a mainframe strap by threading the tang male end upward with the buckle housing facing the center of the NX through the slot of the patient's surface near the head end of the NX. Wrap the strap around the slot and fasten the buckle. Leave a little slack in the strap for final adjustment. Repeat this step with the other mainframe strap. You may need to adjust the neonate's position on the NX to accommodate the patient properly. After doing so, tighten the backrest strap and both mainframe straps.
So that was the Neomate. And then the final product is the Kangoo Fix, which is made for your newborns born in the scene. It's 3.5 pounds to 11 pounds, so 1.6 kilos to 5 kilos. There's no video for this product, but you can really show that it's a 5-point harness that attaches to the ambulance cot on top of the mother or caregiver. So it allows close contact between the parent and the baby. It is easy to clean, lightweight, easy to store, and you can do it where the child is either forward facing outward or facing towards the mother inward and cocooning. There is a blanket as well to keep the baby warm. And we'll talk about how important warmth is later on in the program. A few other items that are out there is this is basically like the PEDReady, just made by a different manufacturer. Again, same age range, weight range as the PEDReady. Then there's another option, the Deluxe Pediatric Child Restraint, which is, again, kind of looks like the PEDReady. And then there are ones that are air-filled child restraints that you could use, again, only for a certain amount of ages, though. So it's rated for 20 to 40 pounds. You would have your pump that you would fill it up with. So it is just an option for those certain ages and weights. And then some ambulances now have the captain's chair that has the car seat in it. Again, this is for specific ages and weights. This is 9 kilos to 23 kilos or 20 to 50 pounds. And that they have to really be able to sit up unassisted for a few minutes and maintain their airway and good head control during the entire transport to sit in this. A lot of people ask, can we use car seats on stretchers? And there are some do's and don'ts when it comes to car seats on stretchers. You do want to use a convertible car seat. And what is a convertible car seat? It's one that has the 2 points to where you would place the belt pathway through the car seat themselves. So you can see in this picture, it's kind of in the upper and the lower. And they will still have the 5-point harness of the car seat. You do not want to do an infant car seat that is meant for rear facing. There's only one pathway for the belts to hold it in. And you never ever want to put a car seat on the bench seat of an ambulance. So you either want to put it on the stretcher, or if you have the captain's chair, using that built-in car seat. And again, we're going to reinforce with visuals that please do not have them hold the child in their arms. So when we talked about, there is a resource out there for NSEMSO. It is a comprehensive list. There is a brand new one coming out in 2022, and it really goes over a list of sick, not sick, what's the best use for these car seats, and safe transport products out there, and really kind of going through all of them. So I encourage you all to look up this list and read through it. So now I'm going to turn it over to putting all of this into practice.
Hey everybody, my name is Tracy Voss, and I'm the Chief Fire Administrator and Emergency Services Director for the Walton County Sheriff's Office, and I'm also the Rural EMS Liaison to the EMS for Children Committee. Now that Nikki has talked about all these different product options, let's talk about the overarching developmental issues when we're using them. Oftentimes we hear that it's easier to have parents hold the child when you're transporting them in an ambulance simply because they don't cry and they stay calmer. What is clear is that different age groups will respond differently to being separated. A few tips for us to keep in mind here is that the neonate age group, they're usually easy to separate, and even though they communicate through crying, they're not necessarily as anxious when you separate them from the parent. One thing you can do as a provider to, in a situation of separation, is to provide a secure comfort hold while you're transferring them from the caregiver to the stretcher. Instead of holding them straight out or holding them in a way that could cause stress, you just hold them close to the body, use slow movements. Don't stroke them, things like that that could stimulate them. Separation anxiety can peak at varied ages, and it's very dependent on bonding, as well as any developmental factors that may impede or heighten bonding between the patient and the caregiver. Infants 29 days and older, or up to 1 year, can often be distracted by simple things like blankets, toys, even singing, like the alphabet song or Wheels on the Bus. It's good to have the caregiver stand close to them, and if it's appropriate, to allow the caregiver to actually help buckle them into one of these devices to reassure them, then certainly that is worth doing. Toddlers, on the other hand, anxiety will likely be present when they're separated from a caregiver. One strategy is to use simple words, phrases, and visual cues, things that reassure them. A smile goes a long way just to help reassure them that everything is okay and they're safe. Asking them about colors or items in the ambulance. Again, singing the alphabet song or Wheels on the Bus, those are great distraction techniques. And like with infants, having the caregiver close, and when it's appropriate and safe, encouraging them to participate in securing the child in the ambulance is a good thing to do. Probably, and those things are all predictable, you know, how your children are going to behave. What's typically unpredictable for the parents are going to behave. They're likely going to want to hold the child, be close to the child, or in some way be a distraction to the provider when the provider is trying to give care. Don't hesitate to tell them that they're being restrained in the device that you choose, simply for the child's safety. And it's best when the child is secure in an approved transport device rather than on the stretcher or in the parent's arm, way safer. So just to summarize this, neonates and infants, they experience less emotional trauma when they're separated from the caregiver. It's important to keep them warm and having a soothing voice. Those things are very important to help keeping them calm. You should provide neonates and infants minimal discomfort. And that's simply just by warming your hands or not touching them with a cold stethoscope. It creates anxiety and has to be avoided. Separation anxiety for toddlers might be a little bit more intense when they're working with caregivers or their parents. They can be sensitive to touch and be fearful of suffocation when you're trying to put an oxygen mask on them. And they perceive that they're in trouble after they've been injured or they're ill. So you have to reassure them verbally with kind and encouraging words, and visually with a smile or some other age-appropriate distraction. Reassure them they're safe and they're not in trouble. Fear might be mitigated by providing honest, age-appropriate words to prepare the child for an IV stake or some painful procedure. Use distraction techniques to minimize pain when it's possible. Again, for the caregivers, common emotions may include fear, guilt, anger, sadness, panic, the entire range. So, as a provider, you have to work to normalize emotions and redirect your attention to assisting you with the child and to help provide emotional distraction. Remind the caregiver that the infant and child and the parent and the caregiver, they're safest when the child is secured properly in a device that keeps them safe in the ambulance.
So like we discussed before, our working group had three objectives. One was to develop an educational content, which is this. The second was to develop a position statement that was endorsed by multiple agencies, which we discussed before. And the third was to develop a sample protocol or policy that agencies can use, with the goal of agencies to, really support safe pediatric transport and develop a practice of such. So here's a policy template that we developed that includes a background, which we discussed, indicating how many crashes there are per year, and includes the NSEMSO's statement regarding that safe transport should be equivalent to an open airway and maintenance of cardiovascular circulation. And then it also includes a statement saying that a pediatric restraint device should be approved by the medical director and should include the ones that the agency chooses. So like Nikki said before, we don't endorse a particular product by any means. So whatever your agency decides to choose, you would put that in the policy there. And then it concludes by saying that it's never appropriate to transport pediatric patients unrestrained in somebody's lap or using horizontal stretcher straps that don't fit. So we all know those stretcher straps. If the patient's too small and doesn't fit in them appropriately, it's not okay to transport them that way. And like EMS medicine is proceeding, we like to do everything either evidence-based or guideline-based, and we have some guideline resources at the bottom. So feel free to use that and develop your own policy, and that'll help with, like Chief Voss said. Sometimes the most difficult people on the scene of these calls will be the parents, and if you have a policy in place that gives your EMS clinicians a backing to say, we have a policy in place, we're not allowed to transport your newborn on your lap or on your chest. Here's our policy. We have to transport in an appropriate device. So now we're going to move on to frequently asked questions as a conclusion.
Excellent. Thank you, guys. My name is Kevin Mead. I'm with Florida EMS for Children. I'm a paramedic for 20 plus years. Over those 20 plus years, I've had a lot of pediatric transports, more than I would like to have had. So we kind of use this section to predict the most common questions that we have. There are questions that we're not going to cover, but here's some of the most common questions. If car's been in an accident, can we still use the car seat? Yes, you can, as long as there's no major damage to it. Basically, the National Highway Transportation Safety Agency has said that reuse of child safety seats can be used in a minor crash only, which means there's no major vehicle damage. The doors were open. The door nearest the safety occupant was undamaged. Nobody was injured. The airbag did not deploy, and there's no visible damage to the safety seat. Most manufacturers of safety seats say that once they've been involved in an accident, you should replace them. If we're using that, if that's our best option to use that seat to get the patient to the hospital and they need to go get transported, then we have to make sure that we're using a safe seat, visually inspect it, and secure it properly, only if it's one of those convertible seats that we can secure properly. What about the early mother-newborn bonding? This is a topic of much debate, but there's really no data to indicate that short-term separation is detrimental to either the mother or the baby. Everybody wants to hold their baby. Everybody loves their baby. We all understand that. However, the amount of time they're going to be separated will not have any effect on the child. And if we do let them carry the infant on their lap and something happens, tragedy will ensue. So we will never let them ride on the parent's lap due to bonding issues. They will have plenty of bonding time when they get to the hospital. Can we keep them warm? Of course we can keep them warm. So, we can use blankets, space heaters, warm packs wrapped in towels. turn up the heat in the ambulance. We've often in our world done a lot of things that are easy for us to make our world easy. We have to remember that the patients are the ones that need to be taken care of. So if it's 90 degrees out and you're hot, but you need to keep your patient warm, what do? We put the heat on in the back of the ambulance, and we make sure that they are kept warm during transport. Here's a list of a lot of resources. The SIMSO is up there. The EMS Improvement Center, EMLRC, PEDReady is a wonderful resource. That's your local Florida EMS for Children website. We have tons of resources. Of course, this group is always available. You're more than welcome to reach out to Florida PEDReady, EMSC. There's your contact information. We would be more than happy to help you in any way we possibly can. Thank you so much for listening to our presentation, and continue all the good things that you do.